So what we're going to do is I'm actually going to run through two of the cases from my first talk rapidly, and then we can do a bit of question and answer with the panel around those two cases, one at a time. And then the second two cases are more complicated, and they're in a different talk, but I'll pull those up. And those are, yeah, much more complicated cases. But yeah, and we had a case that someone at Dr. Sheckett had typed up that I wanted to also speak to. Can you hand me that folder there? Because we'll bring that one up too. Okay, so, you know, we only have 45 minutes really, so we'll see what we can do. This is actually the second case. I'm just going to go back to the first case. Here we go. So this is a patient that I saw at the pain management clinic. She's a 55-year-old care aide. She had right shoulder pain and sleep and mood disturbances. She had an MRI evidence of full thickness tear and atrophy in supraspinatus and a possible tear in subscapularis, tendinopathy and infraspinatus, fluid in the subacromial bursa, and deltoid bursa. So she had some pathology in her shoulder. Orthopedic surgery said conservative management only, given her age and things. They didn't want to do any surgery or any other interventions or even injections. So she was sent to us. We decided to try a little cortisone injection anyway, a little bit of help. Her mood, she was only sleeping 2 hours a night, she said, and often, you know, patients don't really know how much they're sleeping, but she was anxious and tired. Her past medical history is she'd had a previous shoulder injury which had resolved, so this one was confusing her. She had asthma, hypertension, hyperlipidemia, obesity, and depression that was treated for the last 12 years. So I'm going to go over her medications. So she came to us on Tylenol number 3. She was taking 2 every 3 hours, up to 12 a day, but she was running out early because it wasn't controlling her pain enough. So 50 pills were given every 2 weeks. She was taking anywhere from 3 to 4 pills a day on prescription that would allow, but since she was taking so much more, that's why she'd run out. So she would go to Tylenol 1s over the counter, 3 tablets every 3 hours, up to 18 a day when she was out of her Tylenol 3s. She was also on, so first of all, just any thoughts about that dosing schedule for opiate medications?
It's quite a bit of Tylenol.
Yeah. Yeah, it's quite a bit of Tylenol. And if you don't ask about I always ask about prescribed medication and then over-the-counter medication, and then I do my substance use history, starting caffeine, nicotine, alcohol, the most unthreatening things first, right? And then you move into marijuana, opioids, cocaine. You know, usually coke do toward the end because that's more threatening for people. But yeah, so quite a bit of Tylenol.
It's a big assumption to make, but is she taking this for her shoulder pain?
Right. Is she taking it for her shoulder? She thinks she's taking it for her shoulder pain.
And the clonazepam as well, and the oxazepam.
Yeah, so no, we'll get on to that in a minute. The other stuff, we're only just ramping up with what she's on.
And well, obviously, you know, uppers and downers.
Right.
You know, with the
You haven't seen anything yet.
Okay.
Yeah. No, but
So
yes, the
I think I know this
methylphenidate's down
person.
on the list. Yeah.
So I mean, you know, I'm obviously wondering about sort of diagnosis
Yeah.
and short-term versus long-term treatments and short-acting versus long-acting agents, and being on multiple agents in the same category, 2 different benzodiazepines.
Yeah.
And just kind of wondering, you know, what's going on here.
What is going on? So what's underlying this is multiple providers. She had a family physician, then she had one psychiatrist who then retired, and that psychiatrist didn't want to stop what the family doctor doesn't want to stop what the psychiatrist started. And then the new psychiatrist didn't want to stop with the old psychiatrist, so they just kept adding meds. That's how she got into this mess. And she doesn't know anybody. Her own lived experience is she's not sleeping and she's in pain. That's her lived experience. But this is how we spiral into this mess. So yes, she went on to clonazepam several times a day during the day and oxazepam at night. And doesn't make any sense to us pharmacologically, but that's what was being prescribed. Then because she was sleepy during the day, as one can imagine, she was put on methylphenidate, on Ritalin. 20 milligrams 3 times a day. And I I'd say about 5-10 years ago, there was a fair bit of this going on. When patients were on too high an opiate dose, especially when combined with benzos, I'd see them coming in, often from pain clinics, on a whole bunch of stimulant on top of that, and it was thought it was a viable solution. Well, there's other options here. Don't put them on stuff that's so sedating or that's too high a dose for them instead of stimulating them over. Right. So you guys are already on top of that. She was also on trazodone 300 a night, chloral hydrate 500 milligrams a night, risperidone 1.5. Rabeprazole for, reflux she's having with all this, and a bit of Singulair, some salbutamol and Advair. Also diltiazem, she's on fascinapril, hydrochlorothiazide, for her hypertension. She had failed antidepressants, tricyclics, and neuromodulators. And so she had the stimulant to keep herself awake, an opiate and anxiolytic during the day, and sedative hypnotics and antipsychotics to sleep. So it's a matter of peeling her off of this, right? So also, we always have to take our substance history, starting with caffeine, just a cup of coffee 3 times a day. Tobacco, half a pack a day, down from a pack. Alcohol, she was doing 1 drink every, either up from twice a week up to once every 2 weeks. She understands it's contraindicated, but around the age of 30, she had 4 to 5 years of problems. Where she was drinking a bottle of wine a day, sometimes only once a week, but her kids had to be cared for by her cousin. She was in an abusive relationship and ended up getting divorced. So there was this time that, it looks like she may have had an alcohol use disorder, or at least things were out of control for her for a while under a very traumatic situation that then cleared up. So she may have reamed up her tolerance. We see that a lot where patients who have this a more extraordinary history of substance use may or may not meet criteria for substance use disorder, but certainly they've had exposure in a way of high dose that then really have quite a bit of tolerance for opiates or other drugs, and it's because they've changed their brains a bit. Anyway, no reported other drug use. So she was a very pleasant woman, only 5 foot tall, weighed 230 pounds. Blood pressure was elevated. She was cradling her right arm. Her head was tilted to the right. She had limited flexion, shoulder flexion, and abduction and internal rotation. So she looks like she had a bit of a frozen shoulder going on. She was diffusely tender in the whole shoulder girdle. So her diagnosis, a right rotator cuff tendinopathy and atrophy, mood changes, meds began when drinking and divorcing, still low, anxious, sleep disturbed. That's when the benzos had started, is when she was divorcing and drinking and getting smacked around. And then chronic pain disorder, both physical and psychological, clearly over-medicated, and substance use disorder with alcohol likely, some alcohol abuse in the past, but was in remission with intermittent use now, is kind of how we'd classify her. So also with tobacco dependence, current opiate dependence, with pseudo-addiction, asthma, hypertension, hyperlipidemia, obesity, and a positive work environment. That's the one thing. She loved her work and she had really good friends at work as a care aide. So this is the importance of taking a history and physical, right? You want to make your diagnosis so you know where you're going. So before I say what I recommended, what would you recommend for a case like this? And this isn't too uncommon for what I see, I have to say, in the pain clinic.
Well, it's unfortunately fairly typical in the pain clinic.
Yeah.
Just a number of comments. Firstly, this is the kind of patient we want to totally demedicalize.
Yes.
We don't want to add stuff. We want to start taking 90% away. And that's not something that one individual is going to be able to do, and hence the multidisciplinary approach. But central to that, I think, is the family physician. Mm-hmm. Tylenol 3, as we all know, is a useless analgesic. Mm-hmm. 20% of us can't convert it to morphine. Mm-hmm. So I'm not sure where we're coming with the diagnosis of opiate dependence. Is that what you're basing that on, her Tylenol use?
It's
Tylenol 3 use?
Opioid dependence versus pseudo-addiction, meaning because she's binging on and off, so maybe she's not converting. So it would be the look of pseudo-addiction, because she's actually seeking pain relief, but she has an aberrant behavior, going to the street and going to the pharmacy and getting Tylenol 1s and binging on them. So that's aberrant behavior. But does she have an opiate dependence? We don't even know if she's converting it,
So
right?
this is the question.
Yeah.
I mean, maybe I was...
You mean opioid use disorder?
An opiate use disorder. Yeah, I
It
typed
sounds
that
like
up
more like a
couple
Tylenol
years
3
ago before that.
disorder, because she might not
Right.
be getting any opiates.
She
but
might
you're
not be
right,
getting any opiates
She
at
might
all.
be seeking pain relief.
She might be seeking pain relief.
So
Or she might be, because of her previous alcohol exposure and trauma history, she might be liking the little bit of dopamine she gets from the low-dose opiates she's getting. Who knows?
Yeah, it's complex.
Yeah, it's complex. It's complex.
In terms of if the shoulder is her driving issue,
Mm-hmm.
which I don't think it primarily is, but it's part of the problem.
Mm-hmm.
You know, we often see this, that patients have had an injection, it didn't work, and that's the whole, now you're speaking to an interventionalist, the whole interventional side has been discredited and put aside.
Right.
There are, you know, 6 tendons and a joint. There are basically 7 different procedures we do on a shoulder. And these, when we do them guided, we often see a different response. So my approach to this, in addition to everything else, we just a very small part of the solution, is really revisiting
Right.
a good interventional approach, but most importantly, followed up with good rehab and physio. And by that I mean within the next hour or two of us doing a procedure. It's almost futile to do these procedures, send the patient home, and I'll see you in 6 weeks. We need to capitalize on any relief that we're getting immediately following a procedure. That's the most useful part
Especially
of a
for
procedure.
complex regional pain syndrome. Get them up, get them walking on it.
And
Yeah.
particularly for shoulders.
And shoulders.
So it's a
Yeah.
very small part of her problem,
Yeah.
but I would say that it probably hasn't been adequately addressed.
Good. All right.
I was just, thinking about the pharmacology part of things, which, I mean, we talked about kind of iatrogenic, kinds of issues, and I think that she's obviously got a lot of things going on and a lot of pharmacology that needs revamping in a pretty major way, and it's nice to do things slowly, and I guess you've got to kind of balance that with how much harm is being done, with the pharmacology, how much is it contributing to her current symptoms,
Yeah.
How aggressively, do you need to make changes?
Right.
So I think that would need to be sort of figured out and sort of come up with a plan for how to make a transition
Good.
from multiple agents to less agents, short-acting to long-acting, less effective
Good.
to more effective, basically bring some control, probably starting with one thing at a time and doing it sequentially, and again, hopefully in a way that aligns with what she perceives as her problems, in a way that she feels like you're addressing them.
Right on. So let's do
would
that.
be-
It's exactly what we did. All right. So I thought, her prognosis in the pain clinic was going to be guarded to begin with. And so I tapered her methylphenidate to elimination. Like, why even beyond that? And then tapered her chloral hydrate, all really rapidly. And then we tapered her Tylenol 3s and tapered her Tylenol 1s, and then consolidated her benzodiazepines.
So can I just ask, how fast were those tapers?
So she was in our pain clinic. We're 6 week. I think we extended her to 8 weeks. So we did this over that period of time. But there was some of the stuff, like the benzos, I'll show you. She was still on some because we didn't want to take her off that so fast. As outpatients, you do this slower, over months, not over weeks. But within a pain clinic setting, we can go faster. So I had her discontinue her alcohol, hold or decrease the cigarettes. This is the plan, at least. Physio, general conditioning, weight loss, psych support, self-regulating training. And I called the family physician and the psychiatrist to get them both on. And they were like, great, take her, do anything you can. They were desperate. So she was able to completely off her methylphenidate and her codeine and chloral hydrate within the 6 to 8 week program. Her clonazepam was reduced to 1.5 milligrams just at night, and her oxazepam was reduced to 30. And she was on the same dose of trazodone. I left her on that, and the same dose of risperidone. So I just wanted to do one thing at a time. The rest we'll do as outpatient. Off alcohol, and she'd cut her nicotine down to half a pack. She'd lost 15 pounds in the 6 weeks. Her blood pressure had normalized. Her sleep was still 2 to 3 hours a night. We did not intervene. She used to yell at us from across the room, "I'm only sleeping 2 hours a night." Everyone knew. So, but we got her to at least stop clock watching and get the stimulus out of the room at night for TVs and stuff, and to rest during the other 4 hours. So maybe she only had 2 or 3 hours sleep, but she had deep rest for the rest. So she started feeling much more rested. And then activity increasing. We got her to 45 minutes of cardio a day instead of 10 minutes. And she had improved head, neck, and arm range of motion and posturing. And she had improved shoulder range of motion, posturing. She had She learned relaxation, breathing, and mindfulness. So she said her pain was a little bit better and easier to deal with. Her Beck depression scales went from severe down to mild, and she said, gosh, it's a lot better. I'm much clearer. Imagine that. And much better. She felt much better than before. She said she felt alive and had more energy. So she felt like she got her life back. And that was sustained through a graduated return to work. We suggested continued tapering of clonazepam, and we followed up a number of months later. So this was continuing tapering that and the oxazepam, and then tapering the risperidone down. And I left her trazodone for 6 to 12 months was the suggestion. So that would be the last thing, because you can get such long-term sleep disturbance when you've been on opiates or alcohol. And then she may have lifelong sleep disturbance, so we may not be able to intervene on that so much. And also some patients, without sleep studies, you don't really know what's happening. She could be sleeping more, or she could have sleep apnea, and that's why she's waking up all night long too. Either added to by the medicines she was on, or just because of her physiology. She's short and wide and everything. But what you have to not do is keep trying to medicate her sleep. That's the issue here. That so much of the problem she got into is because docs tried to medicate her sleep constantly, and none of the medicines really had much effect, but instead of taking them off, she'd just go on more and more. So she had a successful completion of her graduated return to work. She was fit without limits, and she was happy to be back in the workplace with friends, and she continued to do well at home. Actually up to about 2 years. And then she had another shoulder injury at work and came back to us, and we went through a bit of the same cycle, but she wasn't on so much meds to have to do it with. So that's one case. Yes? She's not inpatient, but yes, it's 7 hours a day, 6 weeks, yep. 7 hours, 5 days a week. They go home at night if they live in Vancouver, or they're put in a hotel room if they're sent in. So these are injured workers we work with, primarily WorkSafe BC clients, so they tend to be the hardest to rehabilitate. We have a 71% fit to return rate. If left to their own devices, there's a 2 to 3% fit to return. Okay, yeah, you had one question? Right. So if the person, good question, if the person is, I'll just repeat it, if the person is truly resistant to codeine, in other words, they don't metabolize codeine to its active metabolite, and that can be true for tramadol as well. It's the 2D6, cytochrome 2D6 system in the liver. So if they can't convert either codeine or tramadol into its active metabolite, then you're not going to see a big withdrawal syndrome. Yeah, it's just not going to be very effective. Yeah.
I think the other thing that's worth mentioning, with opiates is, people develop different tolerances to different effects at different rates. So the tolerance to euphoric effects can develop quite quickly, but the tolerance to, the constipating effects, not so much. So, I think when people get different, when you talk about withdrawal, there's sort of the dysphoria. There's different systems, I think, that are at play. So whatever effect they may be getting from analgesia may be a different effect that may come out in with regards to withdrawal. So I think it's important to think of all the different systems that are being affected, and that those are happening kind of in different ways, different rates, different sort of times.
Good. Let's do another case. Okay, go ahead. Nelson. I can call you Nelson now.
Just
Nelson.
a quick comment.
All right.
Tylenol 3 also contains caffeine.
Yes, right. Thank you so much. So Tylenol 3 and Tylenol 2 and Tylenol 4 and Tylenol 1 over the counter all contain the same amount of caffeine, 15 milligrams. 4 doesn't. 4 doesn't? 4 does not, apparently. I didn't know that. Pardon? Decaf. Decaf. So if you prescribe MTEC, that is it's like a Tylenol 3 without the caffeine. So some of our patients who are taking high dose, like she was taking, she's drinking 3 cups of coffee a day, but all of that caffeine added up to another like 6 cups of coffee a day. And so that, along with the Ritalin she's on, no wonder she's not sleeping at night, hey? So you gotta detox. I have patients, I treated this really lovely police officer. She was like G.I. Jane. She used to train other cops on stormtrooper intervention with hostage taking kind of stuff. Like she was just like Mondo. But she'd had a really bad mangled knee incident, and they'd gone in there and, drilled holes and tried to get, everything regrowing, and it was just a mess. But anyway, she was on a continuous motion machine at home. So you got G.I. Jane on the couch for 3 months in a continuous motion machine. She was so, aggravated not being able to do stuff. And so she got more and more aggro. So the docs had put her on, something for anxiety. They'd put her on high-dose duloxetine, so she had an SNRI on board. And then she wasn't sleeping. She was getting more and more aggro. So they put her on benzodiazepines, blah, blah, blah. So anyway, I saw her, and I was like, how much coffee are you drinking? And she's like, well, only 5 a day. And what kind of 5 a day are you drinking? Oh, I have an espresso machine. And what are you putting in that espresso machine? 3 shots of Starbucks espresso per cup of coffee. She had 15 cups of coffee on board. And how much did you used to drink when you worked? I'd only have 1 in the morning, right? So I said, until proven otherwise. So we detoxed, plus she was on Tylenol 3, so she had all this codeine on board from that. And when she'd gone on duloxetine, she'd just gotten more and more aggravated, like some of our patients do. It's too much noradrenaline for them. And so, what she had to do is be completely detoxed from caffeine, come off that duloxetine, come off the benzodiazepine, and get up and get walking, get her off that. So anyway, always ask around that. Yes? Yeah, I will. Yeah, I mean, because that's the setting I work in, yeah, I mean, I have... The setting we work in. Okay. Yeah.
Can I just make one comment that sort of got sparked by the sort of agitation part of things, and it's something that I don't think's been mentioned, but because we're talking about opiates and antidepressants and whatnot, is just a word about kind of serotonin syndrome, because we think about serotonin syndrome in the context, I think, of psychiatry and antidepressants, and just to make the point that opiates also are a risk factor for serotonin syndrome, and I think and some opiates are worse than others, so methadone worse than morphine, for example, but if you start getting combinations of SSRIs, duloxetine, trazodone, and somebody on an opiate, just to keep an eye out for serotonin syndrome, which can start looking like agitation, more anxious, and could potentially be quite a serious thing. So just to keep an eye on that as well.
Yeah.
A very quick comment, just to reinforce what Dr. Kahn said about some of the potential value of intervention, and part of it
Yes.
is the validation that when you also do an intervention and it makes a difference within 5 to 10 minutes of having done so, and then they see a dramatic improvement in their pain, range of movement, etc., is that there's an element of buy-in that you've just achieved
Yeah.
with that patient, and that you ask them to do something, there's a really high likelihood they'll do what you ask them to do.
That's right.
So
And you understand them, because the biggest complaint of pain patients is that all doctors think all their pain's in their head. And so if you can actually find something and show them, then they know that you understand them, and then you're right, they'll buy in.
and that can help on an outpatient management basis when involving the family physician in the ongoing management, is that this will be a group plan
Right.
for you to do, and we will help you out.
Okay, so I wasn't going to present this case, but I will, because it was an outpatient. Here we go. This patient I saw when I worked at the Three Bridges Community Health Center in Vancouver, so it was a community health setting. A 19-year-old street-entrenched female youth came in, pierced, tattooed, black clothes, torn, presents asking for methadone. Her past medical history is she had a severe ankle sprain a year prior with an air cast. X-ray was negative. Ongoing pain, emergency visits, labeled as drug seeking. Friends helped her out with pills, and then she went over to heroin. No mood issues. She had broken sleep. Medication, she was on ibuprofen, wasn't really doing much. Acetaminophen, completely ineffective. Her past substance use history: tobacco started at age 12. Currently, she was at a pack a day. Marijuana started at age 13. Currently, 2 to 3 joints a day. Alcohol started at age 13. She was now drinking about 2 beer a week, rare binges. Heroin started about 6 months prior, with smoked heroin escalating to 3/4 gram per day, IV divided 3 times a day. She'd been on the street since age 17, alcoholic father, violent, so she had left home. Recent breakup with her boyfriend. She has a dog, which made it really hard to house her in Vancouver. There wasn't a lot of housing that would take an animal. Exam, she had bony tenderness on the right ankle. What are the next steps? Yeah, x-ray her ankle, and if needed, go to further imaging, even beyond x-ray if needed. And so what would you do about the rest of the stuff going on before we go on? So ankle x-ray, we're going to do that. Excellent. Lab testing also, right? You could help with a white count, see if she may have osteomyelitis that might show up. Yeah, CRP, yeah. Ask her if she wants to stop using heroin. Whatever else you're going to do, if you're not going to address what's happening with her heroin, that's difficult. How can you address her heroin if she's homeless, though? So we need to work on Maslow's hierarchy of needs. We have to start with housing first.
But that doesn't mean that...
It doesn't mean you can't talk about the other stuff or that you don't do her x-ray.
Yeah, or even, I mean, if she wants to stop using heroin...
You can start her on methadone even when she's homeless, yeah. But, so do it all, do it all. So I converted her to methadone, 85 milligrams a day. I referred her to community counseling for housing. I did an x-ray, and then that wasn't conclusive, so I went on to a CT and then a bone scan, and it showed an occult fracture and a low-grade osteomyelitis in her ankle. And so we put her on antibiotics, surgical intervention. She needed debridement, internal fixation of that ankle. And temporarily she was on oxycodone for several weeks on top of the methadone. And I just wanted to say earlier, I probably was not clear with what I said about adding a second opiate to Suboxone or to methadone. You can in the acute setting. It's just not wise for long-term chronic pain management. So we added some oxy to her for several weeks, and then physiotherapy, and got her off the oxy, and then slowly tapered her methadone and decreased her tobacco and marijuana with counseling. And she then did her grade 12 equivalent, studied and passed her exam, and applied and was accepted to be a youth counselor. So what can begin as pseudo-addiction, seeking for pain relief, which is how she started her opiate use, can become full-blown addiction. So one can translate into the other. And people who fall outside the average due to class, race, sexual orientation, body ornamentation, age, lifestyle, can be misdiagnosed or not fully seen. That's true with the elderly population. We often miss addiction medicine diagnoses, or women are often missed, especially if they're well-dressed, are often missed, because there is a lot of social stigma around it. We need to treat that underlying condition, if there's an underlying condition that will respond to an intervention of some sort, and we need to challenge ourselves to see the whole person who comes in front of us. Okay, so that's that case. Any comments on that case?
So in that case, would you interpret the start of her addiction problem being her ankle problem, although she had substance abuse before? But
She didn't have opiate use before. She had a bit of, she's smoking a couple joints. I mean, 40% of the youth and 80% of street youth are smoking a couple joints a day. So I wouldn't.
So the driving force in her seemed to be an
was her ankle.
undiagnosed ankle problem.
Absolutely.
And most of her problems resolved
Yep.
once the ankle resolved.
It all
That's
resolved.
really
Plus with
quite-
consistent care and believing in her.
Absolutely, yeah.
She did so well. And this is what Ram was talking about how people can turn around so well, with some support.
So more often you would see that exact case, but the person actually doesn't have an occult fracture, doesn't have, and had a sprained ankle, and maybe that led to them starting to use.
Yes.
But you do an x-ray and you do all the other stuff,
Right.
and they don't have that.
I just want to emphasize, though, the importance of listening to your patient and doing a full history and physical, because sometimes pathology is missed. Like with this patient, the reason I got into, or one of the reasons I got into addiction medicine, is I saw a woman named, well, it's being recorded, so I won't say her name, because her family gave me permission to use her name, but she was a 29-year-old woman who had been sent home by palliative care to die. And I was a resident working on the palliative care service, so I was sent in to try to, with oral morphine, to try to help her down. And I went into her home. She had her single mom was there, hysterical. Her younger brother was trying to feed her Essiac, this herbal swill from Quebec that's supposed to cure cancer, and so she was trying to cure her, because what had happened is for the last year she'd been having abdominal pain, and she'd presented to the emergency room 9 different times. During that time, her friends had exposed her to heroin, and she started to use heroin. And every time she'd go to emerge, the nurse would come in, take her blood pressure, ask her what medications or drugs she's using. She would reveal that she's using heroin. The doctor would come in and say, you're having abdominal pain because you have heroin withdrawal. Give her T3s and send her out. 9 times, except the 9th emergency doc put his hands on her abdomen. No one had examined her. Her liver was in her pelvis. They biopsied her. She had adenocarcinoma of the bowel. If anybody had bothered to examine her earlier, she may have had longer life, or at least been prepared to die. It may have been too late even when they felt her at that point, even if they got her 9 months ago. If anybody had bothered to take a family history, her father had died of adenocarcinoma of the bowel at age 34. So this was just a really tragic situation. And so I couldn't get good pain control on her overnight. And so we admitted her to hospital the next day, and the nurses pushed her under with morphine. So that was it. So quick death, really tragic. And I was shocked at my profession. You know, how can you not see somebody just because you diagnose them with an addictive disorder? Like, why does that make you not see them anymore? So that was fascinating to me, and kind of propelled me into this work. So I think it's super important that, and I contrast that with this study. So that was Lisa, and then we'll talk about Barry, who I saw years later in my methadone clinic in a primary care setting, and he came in with abdominal pain, and I worked him up to put him on methadone, but I examined him, and it did, you know, he had some firmness in his epigastric area to the right, and scanned him, and he had stomach cancer that had metastasized through and eaten into his liver, and he was full of liver mets, so he was inoperable. But you know what? He at least had a nice 6 months in that we diagnosed him early, we gave him really good care, and he married his longtime girlfriend, and he got in touch with his family. He was a retired bank robber, Barry. He was a 67-year-old retired bank robber. He was quite delightful, heroin user, quite delightful. But so anyway, and he got to have a very resolving death. I remember holding his hand in the palliative care ward at St. Paul's, and he was just this waif of a person. You know, you auto-absorb at the end of life when you're with cancer diagnosis. And he just held my hand and he just said, "I love you, Dr. Reeb." And I said, "I love you too, Barry." And he just died the next day. He was just really floated off. So not to say that all of our patients die, you know, but and not that you're probably supposed to say "I love you" to your patients. That's probably, you know, gets you college reprimand. But
I think your point about seeing people for much more than just their addiction, if they have addiction, and you know, seeing people in a holistic way is really critical. And you know, one of the most common things that I hear from my patients who are suffering from addiction in relation to the healthcare system is that they have been treated horribly almost all of the time, and they often refuse to go to the emergency department with things like yesterday I saw a person at the Rapid Access Clinic who had a hemoglobin of 62, and she had this fit. I've never even seen a fit come back with a number of like 3,000 or something. Mm-hmm. Anyways, I won't go into the story about it, but people generally with addiction, you know, that's an addict, we're not going to do anything else for them. The one reason, though, I said in terms of this person, that kind of case presents more often where someone had an injury and the injury's resolved and they continue to use. I just said that because that's normally the case, not that we shouldn't investigate things, but that kind of case I see as definitely a potential for a family doctor to, you know, start someone on Suboxone or offer them a trial of Suboxone.
Nowadays, I would have used Suboxone with her.
Right.
It's just that this was a case that's like 12 years old. So, yeah.
And that's something that, you know, medically, you know, assuming that, you know, you got an x-ray and her ankle's fine, or, I mean, even if not, starting someone on Suboxone by a family doctor, or at least referring her to get started and then taking her back is something that's, I think, not unreasonable for a family doctor to do.
Yeah, it's fantastic. Okay, we're going to go to the next case. Mr. D, a 47-year-old married at-home father, degree in psychology, no family history of substance use disorder. Age 19, he had an L4-5 discectomy for a prolapse. Post-op, he was given Tylenol 3s. He did mix these with alcohol, and he got a bit high with those. 10 years later, and he got off, everything was fine, worked, got his psychology degree, became a father. 10 years later, he has a recurrent disc and surgery. Initially, it seemed successful, he seemed okay, but then he got increasing low back pain over the next year. His GP tried to manage as best he could, tried a number of different non-opiate medications, and then tried low-dose opiates at first, and ended up on hydromorphone short-acting up to 80 milligrams a day, and hydromorph few times by 5 for the morphine equivalent. He'd run out early. He started to crush them and smoke them just to try to get pain relief, because of that spike, you get more pain relief. He went on to fluoxetine, lorazepam, 4 milligrams a day. And his pain was really still unmanageable on this regime, so the family doc said, I am in over my head now, and referred on to a pain clinic that will go unnamed. He went to a multidisciplinary pain clinic. Medications were altered, and this is the medication he came into the drug and alcohol treatment facility I work at on. He was on all of this at once. Fentanyl patch, 150 microgram per hour, 2 patches per day, 150 milligrams worth of microgram per hour worth of patches, changed every 2 days, even though it's prescribed to be changed every 3. He was also on fentanyl solution, 100 micrograms, the 2 ml vials, 3 to 5 of those a day. A fentanyl film on Solace, 600 micrograms twice a day for 1,200 micrograms per day equivalent. Tramadol, 50 milligrams, 2 of them twice a day, 6 tablets total, 300 milligrams a day. Methadone tablets, 60 milligrams twice daily for 120 milligrams of methadone. Hydromorphone short-acting, 80 milligrams a day, which he was snorting. Morphine equivalent dose was well over 1,830. If you, depending on how you convert the methadone, depending on which conversion scale you do, it could be well over 3,000 milligram equivalent this guy was on. His other medications, he was still on some fluoxetine, on some diazepam as well, plus his lorazepam. He was using decongestants, Sudafed, as more of a stimulant, 2 tablets a day, and caffeine pills to keep himself awake, and drinking lots of energy drinks. But he felt great. And he was running triathlons. So he had that thing where he's on extremely high dose, but he's functional. He's a good dad, he's running triathlons. So he looked like, so that the pain clinic said, oh, he's doing well on this. I don't know if you have another opinion at your pain clinic. This was many years ago, so the pain docs even at that clinic might have a different opinion now. What would you think of that, Richard?
Well, I can say with confidence he's not our patient, because
Yes.
none of us
I wouldn't have presented him if I knew it was your
are
patient.
good at that sort of pharmacology.
Yeah.
I mean, these are tricky. You see, the question is his pain really the cause of his addiction? Because if he's that functional, and if he's running triathlons...
You're saying, is it the pain or is it addiction that we're treating with the opiate?
Well, yes, I am. I mean, the question is, just because he's got a pain issue,
Yeah.
doesn't mean that that's driving the addiction.
That doesn't
now,
mean
if
it's
he's
driving the
running
opiate
triathlons
use.
and swimming and biking as well, I hope.
Right.
But, I mean, that sort of function just does not make sense that you would be able... I would never have seen that in my career of 30 years on that amount of opiate, that you're that functional. And in fact, if you're that functional, then we should be getting you off your opiates.
Or you wonder about diversion as well.
Yeah, all,
doing something
all of
else.
that.
Is he taking those
But
opioids?
at the addiction treatment center I work at, it's a private addiction. I've worked public for many years, but the private one I'm at right now, I see people who are running multi-million-dollar companies and doing, very, very high functioning with severe addiction. So it can be really massive. It's not what we're used to seeing, but boy, there's quite some stuff out there. Okay.
I mean,
Graham?
obviously you'd be really concerned about him not consuming all of those opioids himself.
Yep.
And diverting.
Right, okay. So he came in with all the medicines, and we had evidence from him and from his wife that he actually did take all of that. But he didn't come in because of addiction or because he was concerned or his family was concerned. It's because his wife's health plan said they wouldn't pay $3,000 a week anymore for all of this medication. So he was getting cut off. So he was freaked out that this was not going to go well. So he came in for detoxification. He qualified for substance use disorder because of the way he's using his medicines, but Some patients use that just to try to get more pain relief, because really, so anyway, it was a voluntary admission to medically supervised residential treatment facility. This is not the pain clinic, this is a drug and alcohol treatment facility. We gave him education, 12-step group, one-on-one. His methadone and fluoxetine, we left at the same dose at first, and then we stopped the tramadol on admission. We stopped all fentanyl within 2 days of tapering. We added quetiapine, and no withdrawal is seen. We tapered his methadone over 3 weeks to just 5 milligrams 3 times a day. We held his dose, put him into withdrawal, and then tried to just switch him over to a low dose of Suboxone and then to a Butrans patch, but he didn't have enough control on that, so we put him back onto Suboxone and titrated him to about 6 milligrams a day. And he was maintained at 6 milligrams a day even 12 months later. 6 milligrams a day, he had no back pain. When he'd go below that, he'd have back pain that he couldn't cope with, even with slow taper. Fluoxetine, 60 milligrams a day and tapering after a year, and then quetiapine was in a taper. He attended 12-step daily, had a sponsor. He'd had no relapses despite divorcing. His wife had had enough of this guy, and no more pain issues, and he had a great GAF score. So do you think this was primarily a pain disorder or a substance use disorder? Substance use disorder, but from all accounts, it looked like it started with pain, and certainly the docs who treated him at the pain clinic thought it was pain. Could he have had opiate-induced hyperalgesia as he went up? Possibly, and that's why he was chewing and snorting, because he'd just get his head up above that hyperalgesia a little bit every day. How can it be that the opiates beside methadone can be stopped abruptly without shoving him into withdrawal? One could be he's diverting everything else. I know the doctor who followed him for a whole year, and as far as we know, he was not diverting, because he came into our treatment center. They divulged everything at first, and he'd brought everything, and we'd seen him take stuff, and his wife had been seeing him take this stuff every day. So we don't think he was diverting. His wife left him, so if it was in a family, yeah, so I don't know. So we're saying it's possible he was diverting, right? But he wasn't sedated on the stuff we did give him. Okay, what's the other possibility? If he had opiate-induced hyperalgesia, dose lowering helps things, so he may not have had a big withdrawal. Also, methadone could be just saturating his receptors so much that the other stuff, all it's doing is calming him. It's just noradrenaline calming. It's not actually doing anything. And we see that a lot. Patients who are on these huge high doses, we often will like slash them 50% and we don't see any withdrawal because they're just on so much stuff. They're just so overloaded. And then how can buprenorphine and a 12-step combined control both his pain and addiction issues?
Well, often when people have their addiction issue controlled, then their pain, they don't have pain.
Yeah. And vice versa. You know, if you can help them with pain management, a lot of the principles we use, that even in 12-step or other cognitive behavioral type therapies, you know, helping, what do? We do mood regulation, we do affect regulation, we do triggers, you know, all the training's similar for both pain and for substance use disorders. So those kind of programming can be really helpful for both.
The one real big red flag in there that really tips things over to an opioid use disorder is crushing and smoking, right?
Yeah, so if you have any patient who's crushing or snorting or injecting, or you know, any alternate route, it's a big red flag. But sometimes patients really slip into that because that's the only time they actually do feel pain relief. But that's you've tipped over the edge when that happens.
Yeah, how much is that pain relief versus euphoria that they're?
It's usually euphoria.
I think it's always good. Sorry.
Yes, it seems low, doesn't it? Yeah, that's all he needed, though. We got him to the lowest dose because he wanted off if he could, because he realized he'd gotten out of control with all this because he was snorting it and stuff. So he wanted off, but he got down to, he couldn't go below 6 without pain. So
my understanding is there's evidence that below 12 or above 12 milligrams retention in treatment is much better.
yeah, but that's not for everybody, but yes. Above 12 milligrams, yeah, usually 12 to 16 milligrams, retention is better, and usually pain control is better. But he didn't need that. Just like you can, yeah. I want to get to another case.
Can I just make a quick comment on that case? I think we need to get back to first principles a little more often. It would be very unusual, as I mentioned, for a patient with that degree of function on that amount of opiate. It's unusual. Something else is going on.
Yeah.
It's not his pain.
Great. So I want to do this next case. Again, I saw him as an outpatient. I'm just going to do the case, and then I'll take a question after, I think. Is it, go ahead.
Well, maybe you can speak to it when you're giving the next case too. I think for a lot of us in the room, we have, you know, situations that maybe aren't so dramatic as these, but that may start with an injury or some kind of musculoskeletal thing and escalates into opiate use and the issues that you've talked about earlier of hyperalgesia or whatever, slip into addiction. But how do you take the patient, for example, that guy who went through the pain clinic where we as a system, as a medical profession have said, this is the right way to treat your pain, approach your problem, and we actually create a new problem.
Right, iatrogenic.
It's iatrogenic, and then we need to change the patient's perspective.
Yeah.
Like we recognize these iatrogenic ones in our own practice or whatever and decide. So what are your tools for, like by the time they get to you, someone's already perhaps done that work, but
Yeah.
I'm
No, not
interested
usually.
in the tools of how you educate the patient, change their perspective that actually the problem now is the opiates.
So what I do is I give them a mini talk about what I presented to you this morning. So in a small nutshell, I say, you know, we used to not know this about opioids, but what we found out is this, that they increase your risk of death from overdose, of heart attack, of sleep apnea, so it suppresses your brain stem, so you cannot wake up in the morning. They can actually cause pain in the body through a whole bunch of different mechanisms. So I go through the different things and what withdrawal is like and say, so we didn't used to know that these things were problematic, but now that we do know that, it really behooves me to try to work with you to come down on that. No one tried to harm you by putting you on that medication. They were trying to help you. But we can be doing harm with that medicine. So in the same way, if you knew that if we didn't have an upper dose of ibuprofen when it first came out, and we had patients on 5,000 milligrams of ibuprofen a day, but guidelines came out that showed that this was actually problematic. We would want to taper them down, and we'd have a discussion about why that is, and we would bring them down. And certainly I have patients who are using 5,000 milligrams of ibuprofen, and I talk to them about how hazardous that is, and I bring them down. But it's just, this is a more triggering topic because A, they get dopamine from it, so they're more attached to it, and B, it hurts to come down, like we've talked about. So you need to have that conversation with them and then try to help them down either with the tapering schedules or, you know how I showed you could add in some gabapentin, either if you're stopping abruptly, you can also add that in during your taper. Some gabapentin, some non-steroidal anti-inflammatories. Even if those agents hadn't helped them with their original pain injury, it can help them with the detox pain. So trying to do that and bring them down, okay? This is the art of medicine, and that's what takes to practice over time. So I'm going to go on to this case. Or maybe we're done. 10 minutes? Okay. Let's do another case. One more case. Fast. So, because it brings up some other principles. So a 48... Okay, yeah. I can do it in 5 minutes. Okay, 48-year-old HIV positive, Hep C positive male with peripheral neuropathy, sleep disturbance, cocaine and alcohol use disorder, now both in sustained abstinence for 6 years. His pain he rates as 8 out of 10. The medications he's on is oxycodone with acetaminophen, 6 tablets, so it's like Percocet, 6 tablets every 6 hours, no evidence of a current opiate use disorder, but he's getting no pain relief from it. Thus, 120 milligrams of oxy, which is 180 morphine equivalent daily dose because you times it by 1.5, plus temazepam, 60 milligrams he's taking from his wife 2 to 3 times a week. And he has intolerable experience in the past with duloxetine, venlafaxine, and amitriptyline. So I tapered him off oxycodone because this is a failed trial. He's on way above what we think he should at least start to get pain relief with. So I explained it's a failed trial with opioids. Instead of pushing that opioid up, we want to come down. We lowered him by 1 tablet every 4 days until he was at 1 every 6 hours, and then by half a tablet every 4 days until he was off. As an outpatient, this was this is through the immunodeficiency clinic at St. Paul's, and then I titrated him on to gabapentin. I actually used pregabalin, but I'm going to say gabapentin here because that's what's covered here. I began with a nighttime dose, 100 milligrams would be the example, increasing every 4 days until he's on 300 milligram, and then titrating up his daytime dose. And then if he had no pain relief in 6 weeks at 2,400 milligrams, then I would have tapered him off. If he had pain relief, but it didn't help completely, I would keep pushing the dose till he was on 3,600. Neuromodulators can help ameliorate opiate withdrawal symptoms also, which could help him. And then you could either decide not to prescribe temazepam because he was getting it illicitly from his wife, or you could pick kind of a medium dose and then put him on that and try a slow taper, depending on what you're, doing with him. And then nortriptyline can be better tolerated for sleep than amitriptyline, but he declined that, so we went to quetiapine and titrate up. There's a little bit of evidence of quetiapine for pain. And then sleep hygiene, relaxation, and anger management. He was very angry about a lot of things in life, and so we had to help him with that noradrenaline drive. In the song I played to you earlier, one of the lines from the song was, who needs butterflies when you give me the whole damn zoo? And that speaks to amygdala activation. So again, it's a very natural thing for amygdala hyping, but people can get really into their anger and their pain and really stimulate, and when you get a lot of amygdala activation, it will stimulate dopamine release, so people kind of get addicted to these hostile states. So the result was his pain was better controlled, his sleep was still a challenge, but improving. So he had a really good result. So what if he was binging on alcohol and benzos in this scenario? What would you do?
First of all, I mean, if somebody is actively using alcohol, I'd be pretty reticent to be prescribing benzodiazepines, unless it was in the context of helping him withdrawal off of alcohol, and again, I would consider that kind of a trial.
Right.
I think you're putting yourself at liability for, potential, again, sort of overdose and intoxication and whatnot. So
Great,
I
so
think
the
if
only
somebody's
good use of benzodiazepines is alcohol withdrawal.
Right.
Right. So he'd have to be offered residential treatment. He's not eligible for continued opiate maintenance therapy if he's binging on alcohol and benzos. You could either do a really fast taper off the opiate or just stop it. What if he had requested more opiates instead of less?
Well, my take on this is, again, I think we need to demedicalize. What are we treating? The opioids, in fact, not, as we know, very good for neuropathic pain.
Mm-hmm.
They
Aren't very good.
are not
No.
good at all.
No.
And he's demonstrating that because he's needing
That's
more,
right.
right? So
That's right.
we're just kind of chasing our tails.
And some patients will say, it's not strong enough. That's my problem. Give me something stronger.
Or rather something different. We need to
So
change
you need to
track.
talk to them about that you're opiate unresponsive. Neuropathic pain's often opiate unresponsive. Instead of just now putting them on hydromorph or fentanyl. That's what happens.
Or Nucenta maybe, but I mean, I guess the point I'm trying to make is there's more to managing pain, as we know, than pharmacologically.
Right.
But I don't see this coming through. Perhaps in your clinic it is.
Yeah.
But we need to move patients away from the, I've got a pain, I need a pill.
Right. Yes. Okay. What if he'd had some pain relief and increased function with oxy and was unresponsive to all other medication categories or had some horrific allergic response or something they came in? Because we see patients that say that. Would you still have maintained him on that dose?
Well, I mean, I would be concerned about is he also binging on alcohol and benzos in this case?
If he was not.
If he was not.
Mm-hmm.
So, I mean, with any other person on opioids for chronic pain, prescribing judiciously, making sure that there isn't risks related to addiction, and then monitoring function and treating any increases a child to see how they respond.
Yeah. So once daily oral morphine formulation might be available to him, which could go daily witnessed ingestion if you needed to, if he started getting up to shenanigans with it, and not eligible for carry doses of opiates if he's using cocaine or other illicit drugs if he relapses to those.
One quick comment.
That's it.
I'm always concerned when a patient tells me it's the only drug that works.
Absolutely.
Because that doesn't make sense. He likes the drug for other reasons, perhaps.
So there was a case that, that one doctor had brought up that was very, very similar to the WISP stuff. So it was a 33-year-old fellow who was in a motor vehicle accident and was put on opioids, and then his family doctor said, you should be cured by now, and cut him off. And he went to the street to heroin, and when she saw him, she was able to stabilize him with methadone and then wean him off. And once he was down and off, his pain went away. And so it was that withdrawal pain that reactivated his injury, that really activated. So we're now done.
We're done? Do we
Yeah.
have time for a question or two, or no?
I just want to make a quick point that is slightly, very slightly off topic, but that with alcohol, because it goes to opioid receptors as well, the same thing happens when people stop drinking. They get withdrawal pain that's worsens their condition. And I've seen this with a patient who had shoulder dysfunction. He had like a rotator cuff that when he stopped drinking, it got worse because of the same things we're talking about today. And he was going to use it as a reason to start drinking again. But once it was explained to him that this is related to hypersensitivity to pain, and with time it would go away, it helped him not drink again. So it's just an aside, but just to mention this can happen.
And there
There
is
are
a
patients who-
study in the literature that looks at opiate withdrawal hyperalgesia, alcohol withdrawal hyperalgesia that complements the many more studies on opiate withdrawal hyperalgesia. Okay.
Any other, one last question? No one has a question? No? Great.
Everybody knows everything now. That's great. Well, thank you to the panelists, everybody.